Morning, everybody. So I'm Richard. I'm going to be talking through this, but I think Anna's online as well. So Anna, do jump in if you're, if there's anything you want to add. So we're going to discuss the kind of ongoing work on Your DNA, Your Say, and the findings that we're coming out with at the moment. So next slide, please. So just as background, I think probably many of you are familiar with the Your DNA, Your Say study. It's a global public survey which has been going on for a couple of years, and we've stopped data collection in the autumn and are currently pulling together the analysis of this kind of global public attitudes and concerns related to the sharing of DNA and health information. So at the last count, we've got about 37,000 completed samples. So these are recruited from representative publics across 22 different countries in 15 different languages. And it's an online questionnaire survey with a series of videos that you can see on the right, presented in different languages with subtitles as well. So if we go to the next slide, please. So what I want to focus on, so we talked about some of the results from the global meta-analysis at the GA4GH meeting in Boston, particularly looking at things, the influence of familiarity with genetics, trust, questions of whether DNA is different to other types of information and whether you are treated as such. And what I want to do in this talk is to try and focus on some of the kind of implications for policy and community engagement, which might be more national scale, and situate those in relation to this kind of global pattern. So first, thinking about familiarity and how, not just about how familiarity affects people's willingness to donate and share their genetic data, but also where familiarity comes from. Questions of who's trusted with DNA data, who trusts, how trust differs within population, and what we might do to increase trust. And then to focus a little bit on what kind of specific harms people associate with their DNA, with being re-identified on the basis of their DNA information. So if we go to the next slide, please. So to recap some of the work that we presented in Boston, if you look in our meta-analysis, looking across all of the 22 different countries. So these are countries from the global north, but also from the global south. And we have, across the sample, this consistent pattern that familiarity with genetics. So we asked people, would you describe yourself as being familiar with DNA, genetics, or genomics? And familiarity is consistently associated with these kind of increased odds of being willing to donate your DNA or health information. And that personal familiarity, so that's conceptualized in terms of somebody having had an encounter with genetic health services, or having a genetic condition in the family, or being involved in delivering genetic healthcare, is has this greater association with willingness to donate. But what we also found is that when we ask people how familiar they are with genetics, DNA genetics or genomics, their state of familiarity is quite low. So if you take the UK, for example, it's about 35% of people say that they are familiar, and that varies up to a maximum of 58% of people in Italy and the USA. So then within the data as well, we ask people, if they say they are familiar, how are they, where does their familiarity come from? And this can be from more than one different source. But if you go to the next slide, please, Lindsay. By far the most common way in which people are familiar with DNA genetics or genomics, or just shorten that to genetics from now on, but is by the fact that they're interested in ancestry or genealogy. And then everything else is way down the scale. So this is in the UK only. And if you go to the next slide, that's broadly the same pattern you see across the global populations. What you do see is, if you look at the US data, which I don't think I've included in, didn't include in the final slide deck, the number of people who are familiar on the basis of direct-to-consumer testing is up towards 20%, which compared to about 8% in the UK and about 3% in Spain and even in France, where DTC testing isn't permitted. So there's kind of a variation in how people at the lower end of the scale become familiar with genetics, but for the majority of people, it's because they're interested in ancestry and genealogy. So if you go to the next slide, please. So once we've asked people how familiar they are, we've also interested in how willing they are to donate, and not just to donate their DNA across the board, but also to specific users. And so this kind of pattern's probably familiar to many of you from other work around public attitudes towards data, that people's willingness to donate their data for use by doctors is greater in general than that for use by non-profit researchers, and that both of those are generally greater than for use by for-profit researchers. And this is a kind of consistent pattern across almost all of our data set. There are some interesting exceptions, or at least countries where, so interesting exceptions and countries where the difference between non-profit and for-profit is less than in others. So if you look, for example, at the US, India, Pakistan, particularly have these kind of smaller differences between non-profit and for-profit researchers versus somewhere like the UK. And I think that, yeah, one of the things you start to pick up in this data is the differing roles of for-profit and non-profit actors in delivering genetic research and genetic health care. Right, next slide, please. So to try and make sense of this a bit more, we know from the work that we've previously published on the English-speaking data and other people's work as well, that one of the key factors driving people's willingness to donate is their trust in the people who may be using that data. And so again, if you look across our 22 country sample, the effect of trust on the willingness to donate is pretty big. And this is trust in, here we've pulled together trust in more than one group among companies, doctors, universities. And the overall trust has this important effect, but we also see a matching effect of trust, this kind of directed idea that we know that if you trust in companies, then you are more likely to be willing to donate data to for use by companies. And this kind of, again, makes sense. At a national level, again, to look in terms of here for the example of the UK data, if you go to the next slide. So then you can see again this variation across the countries in terms of how much people trust different data users, how much they trust different organizations with their DNA and health information. And again, the smallest differences between doctors, researchers, and company researchers are found in those countries where we previously observed the less difference in the willingness to donate for non-profit or for-profit. If you go to the next slide. Then at a UK level, and we're doing this country by country across our sample as well, we can look at how trust differs by age, education, and gender, particularly. So in this sample, we found that in the UK, we found that those under 30 and those who are 31 to 40 are more trusting of any doctor, any university, or any non-profit or any company worldwide than those in the older populations. We also found that women are more trusting of university researchers in their own countries, whereas the men in the sample were more trusting of companies and the government. And we found that those with tertiary education were more likely to trust doctors and universities, but not necessarily company researchers. So what we might be pulling out here is a finding that higher levels of education are associated with increased trust in academic and clinical research, but not necessarily in research based in companies. So if we go to the next slide, please. So we then presented people in the survey with a list of questions about what might help them have more trust in the people who are responsible for their data. And the things that come out on the top, again, in the UK sample, are a combination of a kind of reiteration of some of the kind of important principles of research ethics, like the option to withdraw and the option to opt out, and the importance of messaging as well about who's going to benefit from the use of this data and how are they going to benefit, about the kind of clarity of purpose. And so if you go to the next slide, again, this is something that we found consistently across the 22 different countries in our sample, that this importance of knowing who's going to benefit and how, and who's using the data are the kind of consistent findings. So next slide, please. Okay, finally, I wanted to touch on what people, what is it that people are concerned when they're thinking about these questions of trust and willingness to donate? What kinds of harms are people concerned about happening as a result of their DNA or health information being accessed? And who's concerned about what? Again, breaking it down. And here I'm just going to show the UK data. And if you go to the next slide, please. Okay. So what you're seeing here is that the things that are coming out at the top are about the use of DNA and health information by marketing, insurance, and employers. We also have this this consistent concern again across our sample about DNA being planted at the scene of a crime, and it's, I think, illustrative of the kind of the potential scope of concerns. The fact that when you're asking people about their perceptions of risk, you're both picking up things that have a potentially high magnitude of effect, but not necessarily a high probability of happening. But again, I think if you then consider this lack of trust in company uses of data with these concerns about marketing, insurance, and employment, that you're that you're starting to get a picture of what's going on in this in the UK here. So if we go to the next slide, then please. Okay, so just to draw out some conclusions from the from where the survey is taking us at the moment, we know that familiarity with DNA genetics is important, and we're not, again, I think that we're not saying again that it's about education. It's about encounters with genetics that have shown people why this is something that's relevant to them, whether that's because of an interest in family history and ancestry, or more significantly, if that's some kind of encounter with a genetic clinical genetics context. That most stated familiarity comes from an interest in genealogy, and I think again you see this in terms of the distribution of people buying DTC genetic tests, that a lot of this isn't about health, it's about genealogy and interest in ancestry. That the willingness to donate is associated with who's using data and who's trusted with data. And that in the UK, at least, the concerns that people have are around, particularly around companies' misuse of or use of, for their own purposes of data, and that this corresponds with the lack of trust in those users. And in terms of kind of practical implications, we really both the importance of considering how of considering familiarity, and then this clear focus on who's benefiting and how complements the kind of the importance of existing research ethics principles in everyday practice. So I think there's a couple more slides. Just the next one, I think, is just saying, so we're currently writing up and publishing the meta-analyses, particularly around the work that we've already described in Boston, but also around trust and people's concerns about harm associated with the use of their data. And then we're also developing a series of policy reports that are pulling out these national level data in order to situate them in this kind of global context. And we're very keen to talk to people about what would be most useful within those. So, and then the last slide is just to say thanks to, this has been a huge endeavor of an awful lot of people translating, circulating questionnaires and contributing to analysis. So thank you.
I think all of us would echo congratulations, Richard and Anna, on a superb piece of work. I'm going to be a slightly lax chair, Catherine, if you'll forgive me, and let these guys take some questions. Lindsay, have we got anything?
Yeah, so well, the first question at the top is about the pedigree tool. So I'll answer that really quickly. There is a link in the pedigree slides, and when we circulate them, you'll be able to get access to that there. So first question up, any thoughts as to why India has more trust in for-profit researchers than non-profit researchers?
So a few in that we've been speaking to our Indian collaborators about this as well, and one of the I think what we're finding is that the balance between private sector and public sector in terms of the delivery of research and healthcare in India is such that there's often an association of for-profit with high quality, and so this is something that's potentially shaping questions of trust as well.
Yeah, our Indian collaborators were saying that trust in local public healthcare is pretty low because local people see public health settings as unhygienic, and they will seek out healthcare from a private setting out of preference.
That's interesting. Okay.
It's quite a different context.
Has the survey been done, redone after certain ancestry companies sold data?
Do you know, it's been, getting people to do it once has been hard enough. 37,000 completed surveys. No, we're only doing it one time point. And of course, the interpretation of the data, we need to think historically about what's actually been happening globally at certain time points. And I'm sure if we redid the survey now across the world with coronavirus, we'd be getting some different public feedback on data sharing.
You would. Catherine says, how would you suggest this information is used to improve public engagement?
I would say we've consistently found across all the countries that familiarity with the concepts of DNA, genetics and genomics is so incredibly low. And what we're not talking about, as Richard mentioned, is increasing knowledge or understanding or literacy. What we're talking about is touch points to why is this relevant to me now and how does this affect me? And so in terms of public engagement, I really feel it's quite urgent that we do some global engagement strategies, which involves really PR and advertising at this point, I think. So I've got lots of thoughts about how we need to be engaging with experts in social communication. And I think that's really what we should be focusing on.
Okay,
if I could just add as well, I think, and I think that constant upfront message about who this is for and how it's going, and not just the kind of who it's for in the in a kind of aspirational sense, but also some kind of like, this is how we're doing this as well. This is how we're getting there. Is a key part of that public engagement work.
So that's excellent. So you asked Catherine about what percentage consent to sharing of the data. It's a fundamental precept of the consent process that everybody shares their data in de-identified format from a secure data center, and the same is ported across into the genomic medicine service when it starts. That will obviously be delayed now by COVID. So I hope that answers that question. There's a couple of questions on ethnicity, guys. The first one is about ethnic discrimination higher in populations. And there's a second one, 50% were worried about racial discrimination. Have you broken down the level of mistrust along particular ethnic group lines?
We have, so within our UK sample, so to take the last one first about breaking down the level of mistrust along ethnicity lines, we don't have big enough samples from ethnic minority populations to break them down to be able to say anything significant within the UK. And then once you then scale that up globally as well, you're looking at a complex picture in which different ethnic groups are in different majority and minority positions within different countries. So it's yeah, so we haven't gone any further with that at the moment.
But we will be giving all of the data to all the collaborators who've contributed to the project, so they will be able to look at their data sets themselves and drill down in as much detail as they can, so for particular populations.
And Clara had a question for you regarding concerns. To what extent do respondents have specific concerns or patterns of concern? Was there a sizable group that ticked all options?
So one of the questions asked people to give their top 3 concerns, so they weren't able to tick absolutely everything. I don't know if you want to say more about that, Richard.
So yeah, there were the top 3 concerns, and then we haven't yet gone into that to looking at the kind of patterns across specific concerns. What we did do in a previous analysis was to look at the patterns associated with trust and the groups of people who, and so this was in the latent class analysis of the English-speaking data to try and pull out a subpopulation, kind of subpopulations within the overall sample from the UK, Australia, Canada, and North America. And I think that we there identified this what we termed the low trust group, who just didn't have trust in anybody within the groups that we were asking people about. And I think we're going to try and have a look similarly, whether it'll at what level we'll do that, but yeah, to try and pull out questions about what concerns come together.
And also following on from that, the high trusting groups within those 4 countries happened to be white middle class men over 50, I think it was. Or was it under 50? I can't remember, Richard. White middle class men under 50 were the most trusting.
So there's one, this may be tricky for you to answer from data, but were there any insights on public sentiment around Genomics England or UK Biobank's commercial partnerships?
We haven't pulled out the biobank participants' attitudes as a distinct group, and we have no way of identifying if people are taking part in Genomics England 100,000 Genomes project.
I mean, we did some work which is on the web, which is around the NHS social contract and the features that patients identified as reasons for why they would or wouldn't engage. There are some red lines. Commercial interaction is one red line, but that actually, interestingly, I think there's a different, I mean, I don't know this for sure, but I feel that there appears to be a different perception if you're affected by a rare disease or cancer on whether you would be enthusiastic about your data being shared with a company as opposed to being a member of the public in a population cohort. And certainly they said that we recognize you need to work with companies, but actually what we would prefer is that you never use these data for marketing. We don't want them used to against us insurance, but we recognize medicines and new diagnostic tests have to be developed. So there seems to be, if you're affected by a disease, I don't have absolute evidence for this, but amongst the focus group, there was a bit of a divide between the public who were more suspicious of companies and working with them, and those affected by disease. But maybe that mirrors others' experience, Richard.
We found that in our data too. So those with a family history of disease, affected by disease, are much more liberal in terms of data sharing and support for the whole endeavour. Yeah, we found that as well.
Well, I think on behalf of all of us, I can only congratulate you and everybody else who spoke in this session. Thanks so much, guys. We've got a short break.